I'm with Tony. We're gonna do the assessment for cardiovascular right now. And my name is Tony. I consent for the video for education purposes. And here is my sister Teresa. Teresa, can you consent for the video?
Yeah, I am Teresa. I consent for filming for education purposes.
And then we're gonna be upload to the YouTube for the school only, for the education only. Are you allow me to do it?
Yes.
All right. So before we assess the patient, we make sure that's a correct patient for two identification, like the name and the date of birth, and we provide the privacy in the office right now. It closed, and uh, closing the curtain for privacy for the patient. I explain the procedure and washing my hand. So sometimes we just a general question for the patient. Do you have any cardiovascular disease? Do you have any heart problems?
No.
All right. Do you have any problem like when you walking and then you feel like shortness of breath?
No.
Are you on any medication for the heart?
No.
Okay. So just general question for the patient. So right now we're gonna be access for the blood pressure. When the patient come to the clinic, we check the blood pressure when the patient lying down, sit up, or stand up. So we check for the blood pressure when the patient lie down, sit up, and stand up for also static hypotensive. So we check every 1 minute when the patient lie down, sit up, and then stand up. If um, the blood pressure dropping 20 um, millimeter mercury, they positive with also static hypotensive. And also we check on the left and the right side of the arm when the patient lie down and sit up. Uh, so to make sure for the patient, so the difference between the two arms for the blood pressure is about like 5 to 10 millimeter mercury. If it's I would say that up to 15, uh, and then if about like 15 millimeter mercury difference between two arms, we have we say like obstruction for the artery for one arm and more evaluation follow up for for the obstruction area. That is the blood pressure, and then we check for uh, we see we're gonna be check for the venous side for the patient. So can you lie down on the side? We're gonna check for the venous for the jugular vein, and you can turn on your left side, please. Turn on your left side. No, no, just put here. Just turn your head on the left side. So we're gonna be see here. I have to move the camera a little bit to make sure we can see. Can you move down a little bit? So move down. So not yet. This one first. Just lie down first. Turn your head on one side. We're gonna see the mastoid muscle here, and then the jugular vein gonna be palpate here, and then we notice the extension of the jugular vein, and then we're gonna find the sternum area around here. Can I touch you? Sorry, can I touch you here? Okay.
Yes.
And then we elevate to 30 degrees. So I try to get her up a little bit, okay? And then we try to measure the jugular vein extension. Sorry, so turn that side. So we're gonna find the angle of Lewis, and then we're gonna find the jugular vein here, and then we're gonna find the how many centimeter from that, okay? So we're gonna put here. So I'm gonna measure like 2 centimeters from the uh, extension of the jugular vein. Uh, jugular vein extension of jugular vein, and then we're adding like 5. Like right now is 7 centimeter, uh, 7 centimeter. So the normal finding will be like um, 7 to 10. So that is normal finding. So for the patient who got the cardiovascular problem like uh, congestive heart failure and then a fluid overload, the distension of the uh, jugular vein can be go up to the neck, so we're gonna be find out really high, like more than 10. Uh, consider like distance of the jugular vein. Okay, sorry. Now can you sit up for me, please? Thank you. Here on this side. So right now, can you turn the left? So we're gonna find out. We see gonna be see the carotid vein. So we check one at a time. So right now, her left side and this side. So we're gonna check on the left side. So yeah, and then we're gonna be check on a different side. Okay. So during the checking for the um, carotid, we check one side to prevent for uh, obstruction of the blood flow to the brain, and also like we just gently to push down. If we push too hard to the carotid, it can be like vagus stimulation and that decrease the heart rate. So when I do a check for both sides, it's strong bilaterally. There are no uh, bounding strong 2 plus bilaterally. So right now I'm gonna listen to the uh, the carotid artery. I'm gonna listen to the diaphragm first. Then I change to the bell. So I hear the heart sound there, but there are no bruising, there are no turbulent sound, there are no obstruction sound on the carotid bilaterally. So that is the neck area. So right now we're gonna be go down to the chest area. So right now we're gonna be inspection for the chest area. So first, there sternum in the midline. There are no remove of the sternum. Sometimes the patient who got the cardiac surgery, they remove open heart surgery. They remove the sternum out. The sternum in the midline, there are uh, no deviation on different side. There are no any scar. There are no any implant. There are no mass or lesion I see on the chest area. And sometimes we're gonna find a patient who got the pacemaker implant in uh, the on the area either on the right or the left side. We're gonna see the pacemaker, but she doesn't have anything there. So we see the inspection. There are no pulsation. There are no heave, and then we check for uh, the the pulsation of pericardial impulse here. I don't see that usually for the pulsation um, for the PMI only for the skinny patient, and she have the breast, she cover everything. So I cannot see any pulsation there, and there are no any pulsation I see on the chest. There are no hip or lip also. And then after that, we're gonna be palpation for uh, on the area. So we're gonna be palpate to uh, on up the listen area. So where we're gonna start with the aortic area. So we find the angle of Lewis and go on the side on the uh, second space intercostal second page to palpate on the right side of the sternum side. That is the aortic side area. And then we go to the pulmonic on the just reflects to the left side on the borderline of the sternum. So we're gonna be the pulmonics. We just palpate, and then we go to the up, just like the third intercostal down, and then we go to the fifth intercostal to the borderline to the sternum. That's gonna be on the tricuspid area, and then we go to the midline, and then the third intercostal area gonna be here to see. I just palpate. There are um, no root uh, there are no thrill. I'm sorry, there are no thrill. There are no uh, pulsation. There are no lip or hip on the area or even on the upside. And also we gonna be check for the um, when we can check for the aortic on the abdominal side when the patient lie down. So when she just sit up right now, so we're gonna be test everything now, and then we're gonna be check other side later on. And then I gonna be listen to the on the field. Oh, wait, you just lie down, and then we're gonna be check that, and then we're gonna be listen later on. Sorry. So for the abdominal, can I expose you? Sorry.
Yes.
So we're gonna be say like expose you. So we gonna see umbilicus here, and then the xiphoid here. So between here, uh, gonna be the aortic area, maybe on the left side. I had to inspect first. I didn't see any hip or lip or position to see on the area. So the patient with the triple A, they may have some position on the skin. For her, I see there are no position on the skin, and I just slightly to palpate the aortic. I did feel it strong, tubulus for the aortic. There are no bowing. That's a good finding. And then we go to the listen to the patient when the patient lie down and the patient sit up also for 4 points. Okay. So I'm gonna be find out Sam. I'm gonna move a little bit now. So the first one I'm gonna be looking for the aortic area is on the second intercostal space on the right side uh, of the sternum, borderline of the sternum. And then I go across to do the pulmonic area, and then I go down to the up point on the pulmonic area on the second intercostal, second space, um, second intercostal space on the left side of the sternum. And then I go to the up point, the third intercostal space. And I go to the fifth on the tricuspid on the uh, fifth intercostal space, and then go to the midline, fifth intercostal space for the mitral valve. And now I turn the bell back. Turn the bell. Listen everything back. Okay. So when she lying down, I hear S1, S2 regular, no extra hard sound, no murmur for uh, for 5 area. And also I gonna be right now. I can listen to the S2 slitting. For the S2 slitting, that's a normal finding that usually we're gonna be hearing on the pulmonic area. So because the aortic valve, I'm sorry, S2 is the closing of aortic and the pulmonic valve. So when because the aortic valve they closing before the pulmonic, so S2 slitting easy to hear for the pulmonic area. So usually we hear that lup, lup, and then the pulmonic will be lup, 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 some kind like that. So we're gonna be listen to the pulmonic on the second intercostal space on the left area. So here I loop, loop, loop. No, loop, 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 some kind like that. And then now while she lying, so we're gonna be access for uh, aortic, listen to aortic artery. Okay, descending aortic. So sorry, I will expose your abdominal one more time. Okay, so I'm gonna verify the xiphoid, between the xiphoid and then umbilicus about would be like 3 centimeter above. I change to the bell. So for the aortic, I listen for the diaphragm and the bell. I don't see any like the bruise or the turbulent sound. Okay, so now next we're gonna be check for the peripheral artery, but when she's gonna be sit up and then lying down again. So can you sit up for me, please? Sorry, thank you. You sit on this side. So right now I'm gonna be listening for the heart one more time when she sit down. I will listen to your heart, okay?
Yes.
Gonna change the bell. Okay, so the heart sound again when she's sitting up is S1 HU regular, uh, no HR heart sound, no murmur. Uh, and so when she sit up, we're gonna be access for uh, up upper and we can access for upper extremity for uh, the artery. So for right now, we're gonna be see on the hand. We see the cap refill. So cap refill less than 3 seconds is a normal finding, and then we're gonna access for the radial artery. So we can see both side radial. It's joined bilaterally two plus, and then we're gonna be go to the brachial. It's joined bilaterally. And then can you lie down again? Sorry. And now it's gonna be go up and down, sorry. So see, so for the video, it's easy for her to lie down. So I'm gonna be expose her to find out the femoral, and then we go to the leg to find out the popliteal, dorsalis pedis, and then posterior tibial. Okay. So I'm gonna be expose you. Sorry, can you go cover a little bit here for the femoral? For the femoral area, so we're gonna be check for her. I'm gonna touching you, okay?
Yes.
For the femoral area, we're gonna be check here for both sides. So I feel the femoral on the thigh, joint bilateral tubulus, and then I gotta be listen to the femoral. So I listen to the diaphragm and the bell to the femoral. Uh, there are no root, no swooshing sound, bilaterally left and right. Femoral artery. And now we gonna be go down to the leg to access for her like the pop the popliteal accessory. We're gonna be see the knee here on the behind the knee. We're gonna be both side by hand to check for the popliteal. Stitch on bilateral tubulus, and then we're gonna go down to the foot. And we go down to see her foot. Out. So for her foot, so we're gonna be locate for the dorsal lip pedis. The dorsal lip pedis, we're gonna be check for the medial just above the medial malleolus on the medial side for both sides. So check it 2 plus, and then we check for posterior tibial artery. Gonna be like on the lateral side. That's just about like Achilles tendon with a heel tendon. 2 plus strong bilaterally. And then we're gonna be see assessment for just take a look for the patient upper and lower extremity during the assessment. I don't see any like varicose vein. There are no sign any sign of like PVD, the peripheral venous, peripheral vein disease. Sometimes you see the patient who pull down the blood is pulled down on the leg and not circulation, and there are no edema when I see on the lower extremity. I usually to see for the heart patient, and also check for the gap refill for the toe is less than 3 seconds. So uh, during the during the assessment, we're gonna also observation any abnormal finding for the patient. So there are no anything for that during the assessment. So that is the ending of the cardiovascular disease. Can you sit up first? And thank you for joining us. Thank you for joining me today. And then thank you for seeing us. And then have a good day.